So let's continue our NEET PG 2017 question papers. What is the skin condition typically which is being shown? It's a case of melanoma, which is the most common in the white skin people, and this is an example of seborrheic dermatitis. It is more common in the patients who are having it is a case of Darier's disease. More or less in the same distribution, you even get seborrheic keratitis. So this is called keratosis follicularis, which is an autosomal dominant condition. Now, what is this appearance basically called as? So it is called a chicken skin appearance, which is seen in keratosis pilaris. Then what is a lesion shown below? So it is a case of dermatographism, which is typically seen in hypersensitivity. Now the skin lesion which you are seeing here is acne rosacea, where there is a diffuse inflammation of the facial area along with the telangiectasia, which is an important indicator. So on the mobile uMedico app, you can see all these images very clearly. You can answer it, and after answering, you will get a rank, and then you will also get analysis how you answered. Then you can see how other people answered. Out of the 500 people who took the test, how did they answer, and how many answered A, how many B, how many C, D, you will know. You click on A, you will meet all the guys who answered A like a WhatsApp rack, and you click on that guy, you can start chatting with that guy. Hey, I too answered like this, how come you answered like that? So that's how it's a community. It's a community built into the MCQ discussion. So sometimes the other people will post a lot of interesting supporting mnemonics and other things for every question. So that way it becomes helpful. And that way you are communicating with a completely unknown guy somewhere in Jammu Kashmir or somewhere in Kerala. And there's a lot of fun in taking a test, checking how it is. Another thing we are going to improvise in the next version is, when you look at how many answered A, B, C, D, suppose correct answer is B, and you have seen who answered A, you found the topper of the exam answered A, that's he answered wrong, you also answered wrong, you're a happy man, right? So that is the advantage of uMedico. So please download the app, you will be given a free enrollment into it and activation into it, and solve the mock test on the app. Now what is this image typically? This image is androgenetic alopecia, typically in the genetically predisposed condition. And why did you think so? It is bitemporal, and frontal recession is a classical feature. Now these are called exclamation marks in alopecic scalp, and they are typically found in case of alopecia areata, which has an autoimmune basis. Once more, water scarring alopecias, non-scarring alopecias, all that rut you have to master before you go to exam, and after you become topper, forget it. That is the unfortunate part of the entire story. Because tomorrow when you become a gynecologist, why do you need a alopecia areata? Huh? Which grade of acne is being shown? Grade 3 has got a small and big inflammatory lesion that are very deep and painful. That's the reason it is grade 3. Now, these lesions, where do you see classically? Typically in tuberous sclerosis, you find this kind of macules are the classical feature. Now, what is this condition which is being shown? It is rhinoderma, which is a dry, leathery and scaly rough skin. A young patient with sudden onset of dyspnea and chest pain with a non-stop flight injury for 16 hours. So non-stop flight injury also is a predisposing factor for deep vein thrombosis with pulmonary embolism. So his chest CT contrast is being shown here. So you can see the presence of the vessel occluded by the thrombus, which is classical of pulmonary embolism. Now here you see the herniation of the lung, which is the classical radiograph of the herniated lung. Then typically pulmonary aplasia is being shown. This is the pulmonary aplasia. This hyperintensity is typically, it presents with a white hemithorax on the chest X-ray. An elderly woman complains of shortness of breath, then radiograph is being shown. What does it basically suggest? If you look at the gas shadow in trachea, it is typically occluding, which is highly suggestive of tracheomalacia. And a lot of times it will be unnoticed, but coincidentally, when you take radiograph and someone is very observant on that, they can be able to catch it. Now, in this you can see there is a thickening of the bronchi, which is a classical thing you see whenever the patient is having bronchial asthma due to the hyperreactive edematous airways occluded by mucus plugs. So, in case of squamous cell carcinoma, when there is a hilar mass and collapse of the right upper lobe, what is this known as? So, typically that is called as a golden S sign. Golden S sign is whenever hilar cancer. What are the two types of histopathologies of bronchogenic carcinoma that presents like a central hilar mass? S for squamous, S for small, C for central, SSC. Our 10th class they used to call SSC, no? So, small and squamous are central, presenting with a hilar mass. When they are central with a hilar mass, typically, there is a collapse of the right upper lobe, and that creates a golden S sign in small and squamous cell. Adenocarcinoma is peripheral, and it is also called scar carcinoma, is the name given for adenocarcinoma. Smaller, squamous and small. Small cell carcinoma is central, hilar. Squamous cell carcinoma is also hilar. Adenocarcinoma is peripheral. In the lung. Yeah, that's why we are talking about lung. Where else you are taking skin? Adenocarcinoma is there in the lung, no? Adenocarcinoma is whenever there is any peripheral scars. From that, adenocarcinoma arises. There is an adenocarcinoma in lung, there is adenocarcinoma, large cell carcinoma, small cell carcinoma, squamous cell carcinoma. Whatever the word cell you are talking is a variant of small cell. Yeah. So, and small cell rapidly spreads. Chotu bahut jaldi bhagega. So, by the time you discover only small cell carcinoma, you will have metastasis. That is the reason, favorite question in the entrance exam. What is the treatment of choice for small cell carcinoma? Never surgery. If you have to do surgery for small cell, you have to cut whole body because already metastasis occur by the time of detection. So, radio and chemo are the ones which are. There is squamous cell carcinoma like a Pankos syndrome, which is a cavitating lesion. They cut. That has got a role. Surgery has a role in squamous cell carcinoma. Chemo and radio have a role in small cell carcinoma. So, whenever you fall short of such a concept, like you are constantly doing wrong in bronchogenic carcinoma topic, you have to read in pathology, you have to read in medicine. But we feel lethargic. Why to read? Why to read? We keep on postponing, and we keep that as a very big thing in the exam, and our confidence falls down. Sit and then strike it. Take 1 hour time, you are the king in the topic, and next time you won't do wrong. Once high yield topics list, do you have the high yield topic list? Yeah. So, look at the most commonly asked topics. 90% question paper comes from that list of 600 topics, which I have given you, right? So, out of the 600, even if 300 without any completely end to end, if you master, you will be in the toppers list. But lot of people don't do that. Why? Procrastination is the thief of time. let me propose next week, let me propose next month. Like that you keep waiting for a better day to come where you can give a rose to a girl and the girl will fly away to New York after finishing US ceremony. So that's the reason, don't what you can do today, think that tomorrow you don't have time. Today is the end point. That is how you have to prepare when you go to reading room, right? So don't postpone, that discipline you need to get. Even tomorrow as a clinician also, you can't think, okay, let pleural effusion grow a little more and then I will do the drainage and check. Already when pleural effusion is seen, drain it and then see TB or no TB, or a simple syndemonic effusion, shall I put antibiotics or TB treatment? One of the things should be decided by the end of the day. So that is called as clinical aggression. So that starts all the way from the days when you are preparing for entrance, let me tell you. That's the reason those who are toppers in the entrance obviously have that inbuilt discipline and do it now kind of an attitude. If not I, who else can also is another important attitude. When you have those, they are all very good when you are becoming a clinician and a practitioner. So 75-year-old underwent pulmonary resection and his condition got worsened. What you can see is from the bronchus towards the pleura there is a fistula. So it's a bronchopleural fistula that the patient has developed. So this is called a scimitar syndrome. Whenever there is any anomalous vein along the right heart border, it looks like a Turkish sword, which is called scimitar sign. You should first see that scimitar, the Turkish sword, how it looks like. But what is anomalous pulmonary vein? Let us talk about it for you to understand the story. So normally, if you take the lungs, if you look at the pulmonary veins, obviously pulmonary veins drain into left atrium or right atrium? Left atrium. So the right pulmonary vein, left pulmonary vein are supposed to drain into the left atrium, right? And SVC and IVC are supposed to drain into right atrium. Sometimes in anomalous pulmonary venous circulation, the right and left combine to form a common vein, and that common vein either comes and drains into SVC and through that into the right atrium, or directly into right atrium, or sometimes the common vein comes and drains into IVC and then it goes up and drains into right atrium. So whenever this common vein of the anomalous pulmonary vein comes and drains into IVC, then along the right heart of the border, it will be descending down to meet the IVC, and on radiograph it looks like a sword, which is called scimitar sign of anomalous pulmonary vein is what you need to remember.